It's nice to see people from all over the state. It's a wonderful thing about Zoom. We can get all of you. My name is Colette Potts. I'm the Director of Recruitment and Outreach at Response to Risk Research, which is part of Beth Israel Deaconess Medical Center, which is one of Harvard's teaching hospitals. The name of this presentation is Recognizing and Responding to Signs of Risk for Psychosis in Students. So who we are. So we are part of one of Harvard's teaching hospitals, Beth Israel Deaconess Medical Center, the Department of Psychiatry, the Psychosis Research Program, and we are a part of that. We're called Response to Risk. We are a research group responding to the risk for psychosis, studying early interventions, delivering early interventions. We're psychologists, researchers, research assistants, co-op students, clinicians. And what we do, we research, but part of that is we offer evaluations, we offer consultations, we offer just friendly, factual conversations about psychosis. I think that's one of the best things that we offer the community, and we offer free trainings, which is what you're attending right now. This is research, so we need to let you know, this is what we have to disclose. We have nothing to disclose. Our work is supported by the NIH, the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Massachusetts Department of Mental Health. And Michelle and I have no direct financial interest in this work. So we always love to do this. We'd like to get a feel for the role that you have in your school. In addition to the chat, we're going to give you a poll. Tell us what role you're in. Tell us how comfortable you feel with talking about psychosis or recognizing signs of psychosis.
Awesome.
Okay. All right. So good to know that maybe the other is a lot of guidance counselors, which is not the same as adjustment counselors, but we've got a lot of adjustment counselors, social workers, psychologists, mental health counselors, teachers, we got a couple of nurses. That's great. Looks like we're split down the middle. For half of you, this is not your first training on psychosis, and for half of you, this is. I'm really excited for both of those groups. In terms of how confident you are in recognizing signs of psychosis, we have a lot of somewhat confident. That's good. And some not at all confident, and some very confident. This is great. In your role, likely to encounter a student experiencing signs of psychosis. Most of you are likely to encounter a student experiencing signs of psychosis. This is great. This is wonderful. Thank you for doing that. Okay. All right, so the agenda, we want to match this to the name of the talk. So we're going to talk a little bit about the importance of your role working in high school communities. And the first portion will be, the content will be recognizing signs of risk. So we're going to recognize signs of risk. And then the second part is going to be responding to the signs of risk. So the recognizing part, we'll talk about a case example, the prevalence of these symptoms, some interventions and treatment that we know works and what we offer. In the early signs of risk. How do you know? What are you looking for? And then responding. So what kind of screening do? You feel like you've noticed something? What do you do next? So there's some screening tools out there. And then, the hardest part is like, how do you talk to students and caregivers about this? It's not something that a lot of people are trained in. And then the last portion is just really tons of resources. We want you to know about everything that we know of that is available out there to support your work and students and families that you work with. So we have a lot of research opportunities through our research group. And then there's lots of others out there in the community that we want to share with you. Some take-home points in case you have to respond to a crisis or you only have until 4 o'clock and you can't stay for the whole thing. Some things that we definitely don't want you to leave without knowing. The first thing is psychosis is treatable. Especially when symptoms are recognized early. That's why we're working very hard to let you all know these are early signs, and there's, you can really respond with hope. There's reason for that. Psychosis is more common than you might think, almost certainly more common than your students think. Psychosis is on a continuum, and we're all on it. So everyone on this call will find themselves somewhere on the spectrum. You might be the first person to recognize signs of risk, especially in students. It's just the age and just the time spent with kids. And early symptoms are often easy to dismiss or to confuse with other things that we'll talk about a little bit later. high school student life. I don't know, this looks a lot like my life, and I'm not in high school. So there's just a lot going. We don't have to tell you guys this. There's a lot going on for college or for high school students. Or you can even add puberty on here because that's happening too. School, family, work, friends, college, preparing to launch, preparing for that next step. It's a lot. And so I think a lot of high school students feel this way, if not every day, at some point during high school, and they probably make their way down to your office. And the importance of your role. Time spent with students. Students at this age spend most of their time in school, and you have access to students. Students probably know where your office is. They probably know who you are. It's just a really, really amazing place to be, an amazing role to play in their life right now. You might be the first point of contact with mental health system. A lot of adolescents start by visiting their adjustment counselor first, or a school psychologist. And it's really for some kids, their very first experience kind of dealing with mental health. And then you also understand, that photo that or that picture that we just showed, which is like all that stuff that's going on in a teenage brain and a teenage life. Like, you really understand the context of the academic and social environment. You understand what students are feeling pressured by and stressed by, more so probably than parents, and certainly more so than people who don't have such daily access to high schoolers and adolescents. So you really have your finger on the pulse. So Michelle, I'm going to hand it over to you.
Thanks so much, Colette, for that great introduction. And I want to introduce myself. I'm Michelle Friedman-Yakoobian. I am a clinical psychologist at the BIDMC. I have been doing research, and I've also been a clinician for a number of years, focused on working with young people who are showing signs of risk for psychosis. Our work has been really devoted to, and really depends on, folks like you being able to help students that are experiencing the very earliest signs to know about us, connect with our programs in order to get connected with help that might make a real difference in their trajectory in their lives, and how much these symptoms wind up impacting their lives. So I also want to just take a moment to thank you for choosing to spend a good part of your afternoon with us today. I know and also probably can barely even imagine how busy your lives are and how many demands there are for your time during this kind of right after school period for folks. And so just want to really express my appreciation for being willing to learn about how to recognize early signs of psychosis, what the options are about what you can do to help young people that might trust you and tell you about symptoms that they're experiencing that are confusing to them. Also want to thank you. I'm getting to see a lot of your faces, which I really love. I completely understand when some folks want to keep their cameras off, but I do really find it nice to be able to see the folks that I am speaking to, and also want to encourage you to participate actively today. So there will be some times where I'll ask you to type some things into the chat to tell me what you think. Really want you to ask your questions. You can feel free at any point to unmute yourself and ask a question as well. If it's something that we'll get to later, we will just let you know about that. But really, we want to make this as interactive as a Zoom webinar 3 years into the pandemic can be. So I'm going to start out today by talking about a case example. And this is a composite that's in order to protect confidentiality. It's not any one particular person, but it really represents some themes that are very common among the young people that come to see us in our research programs and our clinical programs as well. So Jess is a 16-year-old agender student. Within the last 6 months, their grades went from A's to D's, and they quit the soccer team. They told their school counselor that they're having some bad thoughts and images, and sometimes they hear whispers that no one else seems to be able to hear. They're worried that their peers and their teachers can see their thoughts, and they've started wearing sunglasses. and I feel like that helps them to feel a little bit safer. But it's attracting some attention at school, and some of the teachers really don't like having them wear sunglasses in class. They disclosed to the counselor that their father was diagnosed with schizoaffective disorder. Okay, so I just want you to take that in, think a little bit about Jess, think about the student. And in a moment, I'm going to ask you to do something called a chat waterfall. So what this means is I'm going to ask you to type an answer to a question in the chat, but wait until I say 3, 2, 1, enter, before you actually enter your comment. That way, all of the answers come in at the same time, and we're a lot more likely to have everyone get a chance to really think about this question for themselves. So my first question is, what could be going on with Jess? So I want to give you about a minute to consider this. Type your answer in the chat, but don't press enter yet. Okay, 3, 2, 1, enter. Awesome. And hopefully all of you can see the chat and read along with me. You'll see lots of things showing up in the chat. And I'm just looking up into my chat to see some of this. So some of the themes that I'm seeing include anxiety, self-doubt. Several people are wondering about psychosis or an emerging thought disorder. Some folks have indicated identity discovery. Someone wonders if there's some problems with the in the family with this father with schizoaffective disorder. Wondering if they're depressed. Wondering about social anxiety, paranoid thinking. Catherine wrote prodromal phase of psychosis, major depression with psychosis, stress around dad's issues, substance use. That's a very nice, Catherine, very thorough, thoughtful differential. Phoebe wrote looking, asking for help or someone to listen to what they're experiencing. Rebecca said they could be experiencing early signs of psychosis or just struggling with the stress of their father's diagnosis. Trauma, worry, appears to be experiencing paranoia, auditory hallucinations, wondering about trauma. Okay, really good answers. I think we got a lot of people being thoughtful about this. Can I challenge anyone to be brave to unmute themselves and expand on what they wrote, or any additional questions they might have about Jess that they would want to know more about in order to think about what might be going on? If you
I would want to know more about the whispering, the whispering and the paranoia.
Yes. Thank you, Lauren. And you're awesome for speaking up. I really appreciate it. Yeah, so we're curious about the whispering, the paranoia. What's that about? What's that been like for them? How's that happening? Any other thoughts?
I might want to do get information about their sensory profile.
Thanks, Michelle. Can you say a little bit more about that sensory profile and a little bit more about that, what you mean by that?
Sure. I mean, being an agender student as well as, wearing the sunglasses, and they may just be very sensitive to what's happening around them. And sometimes puberty and adolescence brings that to a head for, where the body fits in space and the different sensory systems that we have in play. And sometimes it can come out that being overstimulated with sensory things can really cause additional anxieties and concerns and worry. And it could just be that they need a very specific sensory diet to kind of interact with their emotional level at any given time, or some strategies. So I'd just be curious to see, how the body's working with taking in all the stimulus around them.
Thanks, Michelle. That's a really interesting perspective. Makes a lot of sense. Anyone else?
I think primarily just talking to her and finding out like what, I think it's a lot of like looking at symptoms and then kind of saying like, oh, this is what we are finding distressing, but like, how is she experiencing this? Like what are the things that she is pointing to and can identify? Because I think that's really important for making any of those differential diagnoses.
Yes, thank you, Kelly. So really thoughtful, trying to get a good sense of the experience of Jess and what that's like for them. So I have a second question for you all. Second question, also we'll do a chat waterfall, is what typically happens at your school when a student discloses concerns like this? Okay, so some of the things I'm seeing: referring for an assessment, consultation with school psychologist, speaking with school counselor who may call in-school adjustment counselor or school psychologist, would recommend an outside evaluation, safety screen, referral to school psychologist, meet with a counselor, counselor calls home and connects with a parent, tries to encourage the parent to seek mental health support for their child. Amanda said they're referred to the social worker who would speak with the student directly. We would then get in touch with a parent and determine next steps together: crisis evaluation therapy, go to doctor, etc. Lindsay said conversation with CAC, an informal risk assessment to assess safety before making a plan to re-enter academic learning spaces. Few other people writing about safety assessment, more info gathered from teen and any outside providers, further evaluation around student experiences. Pull together 2 to 3 clinical people, do some thorough interviewing, contact parents, explore deeper support options, consult with parents if appropriate, and refer to guidance. Great, thank you for the thoughtful responses to that. Does anybody feel brave and willing to unmute and expand on what they wrote? Maybe an additional question maybe folks might want to comment on it. What are some of the challenges that might come up if a student like winds up disclosing some of these concerns that Jess disclosed? What are some of the challenges that come up in your role?
I guess I'll go again. So for our school, our procedure normally is, again, if there's a disclosure to a staff member, they would usually recruit the school adjustment counselor to do an initial interview, gather more information, and really just focus on the student first. And then in that context, also do a safety screen in regards to some of the disclosures they're making about, paranoia or hearing voices or worry thoughts or the social discomfort, just understanding more how long have these symptoms been going on, when did things change for this person, have they ever, then you go through your little mental health checklist: focus, attention, sleep, sensory stuff that someone was saying. And then if it's looking as if there could be a potential emerging medical imminent risk that would require attention, that's when our school would consult, I might consult with one other person, and then we would do a level of care assessment or consult with the parents around coordinating provider care around these very specific disclosures that need further assessment from someone outside of the building, because we're not medical people.
Right. Or that sounds thorough. Are you speaking from experience with maybe working with a child that's disclosing possible psychosis symptoms?
I think we just do it. I think I did like 3 things of like that today. Like, it's just, there's always a disclosure where a student says something that might require attention, and I just do a little mental health checklist that if there's something that's emerging, something that's existing, that's changing, if the student already has a provider, do we need to reconnect with that provider and let them know about new things that are occurring? Are parents informed of this? So yeah, that's
Thanks for sharing that. Alexis, I see you have your hand raised. Alexis, did you mean to?
Sorry, I don't know why I'm sorry. I'm signed under my teammate's name. Sorry. I was like, I'm Lisa. Hi. Lisa Winter, not Alexis. And I was going to say that some of the biggest challenges I think come under a grieving parent who is in denial or, fear, just really afraid and overwhelmed and, with the fight or flight freeze response and just lack of timely access to care. I would say would be the top three biggest challenges I've faced.
Thanks, Alexis. I think that many people can identify with those parents who's just overwhelmed, grieving, can't understand or see what the school professionals are seeing and might feel uncomfortable with the idea of further assessment or treatment, as well as barriers to getting care, even if the parents are on board. Thank you. Anyone else want to comment on either on your procedure at your school or some of the real challenges?
Sure, I'll go ahead. I think I'll talk about the challenges. I think I can actually think of a couple of situations where I had to speak with parents about a concern with psychosis and hearing voices and such. And in one of the instances, essentially I got laughed at by a parent who did not understand my perspective on mental health and told me that the real problem was that their child was spending too much time on their laptop. So I would say, a disconnect between the school and the parents as far as knowledge and understanding about mental health concerns. And then the next one that I would say is lack of access, a very overworked and overstrained set of resources in the area.
Yes. Thank you, Amanda. Those are really important ones. And Joseph, I'm interested in your thoughts. I just want to say something about Amanda, what Amanda said first. One, I think thinking about how to talk with parents and the challenges that can come up. One thing I will say, if there's just one thing that you remember from today's talk, I do hope you'll write down our email address. You are working with a student with psychosis, or that you're concerned might need an evaluation for psychosis and you want to talk through with us what the options might be and how to talk with a parent. That's something that we are happy to try to do with you. And we do have some programs that currently are not operating with a waiting list at all. They are research related programs. Not everyone is eligible for them, but there are a lot of resources that are building in the state to make early psychosis care more accessible. So a couple of things that just your comment reminded me of, like, please write down our email address, and we really do want to connect you with resources. And talking through with clinicians that kind of scenario about how to bring it up with parents is something we often do. Joseph, did you want to add something?
Yeah, the other thing I wanted to add was, I think with working with teachers and educators, people pretty much know what depression and anxiety look like and feel like. And I think when we're talking about emerging thought disorders or psychosis, people have a very, very kind of narrow understanding of what it is and what it means, and a comfort level at how to actually support kids who are having those experiences. So I think there's a lot of work that goes into supporting the building staff. And also respecting the boundaries of privacy and confidentiality, like how we strike that balance of need to know versus, making sure that the community is understanding and compassionate and setting up structures that are going to be supportive.
Thank you. Those are really, really important points that I really appreciate you making. One, psychosis is terribly misunderstood, stigmatized, often feared within schools and in communities, often stemming from misunderstanding, stigma, discrimination against people experiencing psychosis. And so one of the things that we really appreciate when we have over 100 people deciding to come and listen to us and learn about this and share information, it's something that's very meaningful to us, because one of our real goals is to try to help people find out where they can get good, useful, helpful information about psychosis and options for treatment. And so really, really appreciate you making that point as well. Okay, so I'm going to talk a little bit more. Psychosis in and of itself, just getting back to Jess, we left that fairly vague. That is a fairly nice example of someone who could be a decent referral for us. Some of the questions that you all asked are things that we might ask a little bit more. If you were to make a referral to us, very likely you would talk with Colette. Colette would ask you some additional questions to get a sense of what else is going on for them. But often somebody is having some changes that are making it hard to tell what's real and what's not real. It's confusing. It's not clear what the diagnosis is. That's often a very good referral for us. And we'll talk a little bit more about that going forward. And it's not necessarily the case that Jess has psychosis or is developing psychosis, but there are some warning signs there, including the hearing whispers, worrying people can see their thoughts, that we would often think about might be worth further investigating. So psychosis is a set of symptoms referring to a disturbance in mental state that causes trouble telling what's real from what's not real. Person can experience psychosis within the context of a mental illness like schizophrenia, bipolar disorder, or depression with psychotic features, but they can also experience psychosis within the context of using certain drugs. Certain medical issues like seizures or sleep deprivation can lead to psychosis. So there are a number of different conditions that can lead to psychosis symptoms. The psychosis in and of itself is an experience, it's a symptom, but it's not a diagnosis. If you've taken a class like Psych 101 and learned about psychosis, you probably learned about some of these symptoms that are related to psychosis. Some of them are the so-called positive symptoms like delusions, which would be fixed false beliefs, paranoia, hallucinations, hearing or seeing things that our mind is creating, disorganization, or the so-called negative symptoms that can go along with psychosis as well, including changes in the ability to express emotion, changes in motivation or social interaction. And those are often less recognized as being associated with psychosis, but they can be very troubling for folks that are experiencing them. So this very lovely, a little bit complicated slide is really just showing our thinking about psychosis being on a continuum. So rather than really in the field right now, folks are not thinking so much that you either have psychotic symptoms or you don't, but rather psychosis is a continuum that everybody can fall on to some extent. So at a very, very mild end, a person may experience some thoughts like, I think my classmates don't like me and talk about me. That in and of itself would not be clinically meaningful. It's a very common experience that kids in your school are probably having. We consider this to be in the normative range, and at the same time, it may fall on the same continuum with more significant paranoia that at a very high end, what we might call full psychosis or the severe end, person might have 100% conviction. There are spies in my school that are stealing my thoughts and putting them on the darknet. Person who's experiencing that 100% conviction, that concern, is really unable to tell what's real and what's not real. The thought is very compelling. It's probably having a pretty big influence on their life. It may also be leading the student to do some things that are really disruptive in their lives, like not going to school altogether, or maybe approaching random people in school and accusing them of spying on them, right? At that high end, we would call that full psychosis. In this middle area is what we might call moderate. And so these are experiences that are bothersome. They have an impact on daily life. They're more than normative, yet they're still significant. So a person might say, my teacher might be reading my mind and recording me. So that's a fairly unusual thought. It's not that likely that a teacher can read their mind. And at the same time, the student still has doubt. They have this ability to wonder whether this is really happening or whether their mind is playing tricks on them. And this moderate area, these folks that are a little more than mild, but haven't quite reached the level of full psychosis, are the clinical term that's used for that is clinical high risk for psychosis. And I'll talk a little bit more about what that means. But a lot of the programs and studies at the Response to Risk program are really aiming at identifying kids that are in this clinical high risk, this moderate category. And the reason for this is a really great opportunity to intervene. If you can intervene before a person develops full conviction about what's real and what's not real, there's a lot more opportunity to use skills and strategies and supports that can help build resilience and help that person continue to have that insight about what's real and what's not real. Just want to take a moment to think with you about how prevalent psychosis is. This is certainly not the most prevalent condition that you're going to see in your schools. Depression, anxiety, substance use, trauma is, in a lot of ways, you're going to see a lot of this as well. But psychosis is actually more common than often people think. So 3% of the population, 3 out of 100 people, experience what's known as a psychotic disorder, like schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features. About 7% of the population, so at least twice as many, may experience what are known as clinical high risk for psychosis symptoms. So those are in that last slide that I showed you where I circled the middle area. Estimates are about 7%, so 7 out of 100. And so you think about the size of your school. If your school has 1,000 kids, that might be 70 kids in a 1,000 kid school that might experience these kinds of symptoms at some point. And as many as 17% may experience psychotic-like experiences. So these might be more in the mild end. They're not terribly clinically significant. They're not causing trouble or really bothering the person, but you may have kids that disclose some of these things without them necessarily having a major impact on their functioning. And then if we think about in Massachusetts alone, estimates are more than 1,000 people per year have a first episode of psychosis each year, and more than 2,000 experience signs of clinical high risk. So again, chances are there may be kids in your school that are having these kinds of experiences. And one of the goals of programs like ours is to try to help identify them, connect them with support resources that can be helpful earlier on. Okay, because more and more research is coming out that lets us know that psychosis is treatable and early intervention can make a difference. So some studies have found that about half of all adult psychiatric conditions start by age 14, 75% by age 24. That's why we love seeing so many people that work in high schools, because you are dealing with kids that are right in that age of risk, a little bit in middle school as well. And a lot of these illnesses begin with very mild, easy to dismiss or easy to misunderstand symptoms. And one of the things that can make it tricky sometimes to identify early psychosis is a lot of kids who may be experiencing them may be doing so very quietly. They might not be attracting a lot of attention. They might not be talking very much. They might be withdrawing from peers rather than calling a lot of attention to themselves, that might be missing school. Early treatment is effective for youth at risk for psychosis.
Michelle, we got a question from the chat. I think it was the slide before that about the prevalence. John's asking, how are those percentages distributed among like the 12 to 18-year-old? If you do you know? I think the question is, would you, maybe it wasn't that one. John, do you want to chime in and explain the question?
I was just wondering which, what are the percentages from 12 to 14-year-olds to, 16 to 18-year-olds?
That's a great question. I don't have the answer specifically to that. We do know that the age of risk for developing psychosis most often is occurring teens to early 20s. So folks that are about 14 to 25 are at greatest risk for developing psychosis.
Gotcha. Okay. Thanks.
But I don't know specifically. And we also know that kids who develop psychosis maybe at age 25 may have some signs and symptoms, very mild, easy to dismiss, that may be there years before. Thank you for your question. And Colette, thanks for helping me monitor the chat. I think I lost the screen, so I will appreciate your continued noticing the chat. So I don't.
Okay.
Okay, actually, this is a good question relating to, this is a complicated slide, but across the bottom here, we've got age, and across, the up and down is relative health status compared to age. And when we think about a very typical course of a psychotic disorder like schizophrenia, most people who develop schizophrenia will function normally in early childhood up through very early adolescence. There may not be a lot of signs and symptoms that are apparent early on. And then around puberty, for some people, it's somewhere between the ages of 14 and 25. We may see some subtle signs and changes, okay? Where maybe a person starts to realize that they can't pay attention as well as they used to. They're reading and they can't keep up with what they're reading. They read it over and over again. Maybe they start to notice their ears are playing tricks on them. They're hearing some whispers they're not sure other people can hear. Maybe colors seem different than they used to. When those experiences are later followed by a psychotic episode, where a person really develops a very significant symptom that makes it hard to tell what's real and what's not real, that period of time before that becomes known as the prodrome to psychosis. Okay, so this slide is showing what standard intervention might look like and what early intervention might look like. Unfortunately, in standard intervention, what mostly happens for the most part in this country, a young person who develops psychosis will often not have, they might have some contact with the mental health system, but they don't get treatment for psychosis until there's an emergency. So a majority of young people who develop a psychotic disorder have their first treatment for that psychotic disorder in the emergency room of a hospital. So it's like, if you think about a medical illness like cancer, for example, it would be like waiting to treat cancer until a person was in stage 4, needed emergency intervention treatment, rather than responding to earlier signs. And most people who get that emergency treatment for psychosis will show some improvement with treatment. There are good treatments that help. But often in standard treatment, a person will go on to have a second episode and a third episode and many more. And they may go in and out of the hospital many times and wind up functioning at a level that's far below where they started out in terms of their potential. With early intervention, the goal is to intervene right when those early signs and symptoms start to show up. Person can't read the way they used to. They're having this thought that their teacher is trying to poison them, and they know that doesn't make sense, but it keeps coming up. They're hearing a voice telling them nasty things about themselves that they know that no one else can hear, but it's still bothering them. When we can intervene with those early symptoms, there's a good possibility of helping people to recover from those early symptoms and to avoid the losses in functioning that happen from repeated hospitalizations. That's the goal of early intervention work in early psychosis. Does anyone have questions about that?
Michelle, a question we got is how this maps out in terms of gender. Is there an increase in risk of, girls or females, or it seems not in my experience, but what do you have a data that says,
Great question. One thing that the field suggests about gender is that we seem to see a little bit of a difference if we think about binary gender. I don't think there's that much research specifically on gender expansive youth as of yet. But for overall, we tend to see earlier age of onset in those who are assigned male at birth versus those who are assigned female at birth. So there seems to be an overall trend where females seem to overall, when you're looking at an aggregate, develop these symptoms a little bit later than boys do.
And then we have another question, maybe that'll be addressed later, is just what are some of the earliest signs that we might see in 12, 13, 14? And then another question about 0 to 10. Would we see any signs in 0 to 10?
Great questions. I think we will get to the question about the early symptoms. We're going to include a bunch of examples of some of that a little bit later. The 0 to 10, it's really rare. It's very, very rare to see psychosis in the very, very young kids under age 10. It does happen occasionally. Our center doesn't have a lot of expertise with that. There are some folks at Children's Hospital in Boston that have a little bit more expertise in early identification and intervention, but we don't tend to see much in early life. Awesome. So in terms of treatment, even though there's more and more research that's mounting that suggests that early intervention can make a difference, the average adolescent experiences psychosis for 18.7 months before treatment. All right, so studies on how quickly young people who experience psychosis get treatment suggest they wait a long time. 60% of psychotic disorders are diagnosed in crisis settings like an inpatient unit or emergency department. And we know that longer delays before treatment starts are associated with functional and cognitive impairments, increased risk of suicide, and losses in social and role functioning. So the longer that a person experiences untreated symptoms, the longer they have to have losses. The more school that they miss, the more learning opportunities they miss, the opportunities for social development are lost, and those things are very hard to make up. So you, in your roles in schools, might be the first to see early warning signs. And you may be in the position to help a young person connect with help and to develop some understanding of what's happening for them, to help connect them and their family with resources that might make a difference. So here's another opportunity for some chat waterfall. If I can find my chat again. Oh, I did. Okay. What do people think? You can either just shout out some ideas or put them in the chat. And we'll do a quick chat. What are some of the barriers? What do you think gets in the way? Why do you think it takes so long for kids who are experiencing psychosis to get treatment? Three, two, one. Enter. Great. I'm seeing lots of stigma, denial, shame, fear, parent fear, just not understanding the experience, socioeconomic status, no psychiatric providers who work with adolescent populations in our geographic area, not enough providers, sent home quickly from the ER, providers aren't aware, don't know what they're seeing, insurance accessibility, lots of insurance access, fear, lack of resources, resource inequities, no awareness of how to help, access, misdiagnosis, no step-down care post-ER. Somebody mixed a question in there about biological-based disorder or other life experiences. We'll get back to that. Waiting list, cultural barriers. Does anyone want to expand on what they wrote in the chat about? I'd be interested in folks' experiences with barriers to care and other challenges.
I would say from a therapist perspective that's working with the client, an adolescent client, sometimes they're not fully open about their symptoms due to, fear of judgment, or sometimes even fear of being placed in an increased level of care, or they're unsure what would happen to them. Those are definitely some barriers. Or if they disclose to anybody, whether that be in the school or somewhere else, maybe being dismissed, misunderstood, not taken seriously, misinterpreted, those kinds of things. So care isn't even sought for after that.
Those are great examples. So people feeling like either there's going to be an overreaction, they'll be pulled out of school, pulled out of learning opportunities, thrown in the hospital, or that people won't take them seriously and listen to their concerns at all.
So another thing that's been sad to see is for a couple of students who have bipolar with psychotic features diagnosis, but receive care through CBHI services, there's a revolving door. And then because the child themselves is in denial and the family doesn't have the resources, then it's like, well, maybe this isn't what's going on. Maybe this isn't what's happening. And then we are seeing repeat episodes, and like, that's just so heartbreaking. So I think even when there is care, the care is not like the right care. And then we just see deterioration.
Thanks for sharing that, Kelly. That is sad. And I think an example of that slide from a few ago with the up and down, sort of in and out of the hospital, and that really takes a toll on a child's development. So here's some of the, I think you guys got to all of these. Stigma, discrimination against individuals that experience psychosis is real and a major concern for folks that are sharing these experiences coming into our programs. Many people are very worried about how sharing these experiences, getting this evaluation, being, connected with this will have an impact on their life. I think somebody touched on this kind of clinician reluctance or lack of comfort with assessing for psychosis. I think that is really worth paying attention to. A lot of people are not necessarily taught about how to assess for psychosis. A lot of folks aren't given a very good, will often leave graduate training with the impression that people who experience psychosis are inevitably going to live a life of disability with no hope for the future, rather than a more balanced perspective that we have at our center, which is most of the kids that we see actually do benefit from treatment and have a lot of possibilities for their future. It can be hard to recognize these symptoms. So a kid that's experiencing trouble telling what's real and what's not real may not know to mention it to a school counselor, because it just seems like what is and what is reality. I also want to just acknowledge, there's a real history of racism, oppression by medical providers that can be really important to be thinking about in terms of level of trust with providers, how comfortable or easy it is, how much privilege someone has to disclose symptoms that they're experiencing, how threatening or challenging it may feel for school to know about mental health challenges that the person is experiencing as well. So that also can be real. And there are a handful of folks that we've seen either in our research programs or in our clinic where the family has been very reluctant to share a release of information with school because they are concerned that their child will be stigmatized in school if the knowledge of psychosis or related symptoms is learned. Does anyone have thoughts, questions, comments on that? Okay. So a few words on how does psychosis begin. Ben Boone, there's a number of folks who have schizophrenia who have written really eloquently about their lives and their experience of developing psychosis. Ben Boone is an example of this. Ben was not diagnosed or recognized for experiencing psychosis symptoms until college, but was a writer and did a lot of writing in high school. Looking back on his writing in high school, can see entries where he talked about worrying that he was losing his mind, being confused about what's real and what's not real. And he wrote in his book that for me, schizophrenia began like a flickering light. So sometimes symptoms were there and sometimes they were gone, and sometimes they were there and sometimes they were gone. And so that experience can be fairly common for folks in those really early, those really early experiences. So early intervention, sorry, I can't see my whole slide. Early intervention, recognizing and responding to clinical high risk for psychosis. Okay. So when it comes to identifying and responding to early signs, we know that most people who develop psychosis experience other mental health concerns earlier in life. So I'd say a majority of folks that we see for psychosis probably showed up, majority of them, not all, may have showed up in some sort of treatment for concerns around depression, anxiety, attention challenges. The earliest signs include changes in mood, thinking, perceptions. And when followed by psychosis, this period is known as the prodrome to psychosis. The signs of clinical high risk can be reliably identified, and increasing research supports the effectiveness of early treatment. There's an assessment that is pretty standardly used in the United States called the Structured Interview for Psychosis Risk Syndromes. This is an assessment that asks kids about a whole host of different kinds of experiences that they've had, including some that are, that really span that spectrum from mild to more severe. And when folks are identified as being at risk on the SIPS interview, about 10 to 25% will develop psychotic disorder within the next 2 to 3 years. Okay, so this assessment identifies kids that are at risk, who are experiencing symptoms that are bothering them. But one thing I will point out that's really important, it's in the afternoon and math might not be the easiest thing to do right now, but I think everybody can probably recognize that 25% is way less than 100%. So again, when we are identifying kids at risk on the SIPS, it does not mean they have a psychotic disorder. It does not mean they're inevitably developing schizophrenia. It just means they're experiencing some signs and symptoms that are worth paying attention to, that are bothering the kid. The SIPS does not identify kids that are experiencing voices for whom those voices don't cause any distress or challenge for them at all. And that happens in the population. There are folks who hear voices for whom that is not a problem, but it identifies kids that are bothered and having some challenges caused by symptoms, but only a small handful of those kids will go on to develop psychosis. So looking back here at this slide, this is where our response to risk programs are trying to intervene, right at these earliest symptoms. So I mentioned the SIPS interview. The SIPS interview identifies 3 main categories of risk syndromes. The most common is something called attenuated positive symptoms. This basically means that the young person is having some psychotic-like symptoms. They occur at least once a week. They've begun or gotten worse in the last year. An example might be Maria has been hearing voices she knows no one else can hear, and she's worried she's losing her mind. So she has insight, she's doubting or wondering, but she is bothered by these experiences. Another category is something called brief intermittent psychosis. These are folks who may have more pronounced, they might be 100% sure, but the symptoms have begun only within the last 3 months, and they only last for a brief amount of time and then go away. So that's more like that flickering light that I described that Ben Boone had talked about. So an example is since December, Javier found himself believing with 100% conviction that Nick Cannon is talking directly to him when he watches America's Got Talent. Afterwards, he's doubtful. Okay. And then a third category is something called genetic risk and deterioration. These are kids that have a first-degree relative, a parent or a sibling, who have a psychotic disorder, and their functioning has gone way down in the last year. So these kids might not have any psychotic-like symptoms at all, but because of that first-degree relative and the decline in functioning, they're also considered to be in a group that's worth monitoring, that's worth sort of the potential for some early intervention to kind of help and recognize those early symptoms. So an example is Manny's mother has schizophrenia. Last year, he was a B student and a basketball player. This year, he quit the team, stopped going to school, and began cutting. Here's another, this is pretty busy. We will share these slides with you after the presentation, so you don't need to commit any of this to memory. This is just giving you some more examples of experiences that might be in that clinical high risk, that moderate level versus minimal or high levels. So, if we look at perceptual abnormalities, someone who's at least once a week sees vague figures out of the corner of their eye or hears a voice they know is not real. That might be at a clinical high risk level, where a psychotic level might be hearing a clear voice they're convinced is a powerful deity that has the ability to control their actions and the future. Okay, so there's no ability to doubt or wonder there. There is a lot of research happening right now looking at what treatments are effective for young people who are at clinical high risk for psychosis. Some of those research studies are being done at our center, but there are several treatments that do have some preliminary evidence for being helpful. These include cognitive behavioral therapy, family-focused treatment, certain dietary supplements, and medications are considered to be promising for young people at risk for psychosis, but those are generally not seen as being a first line of treatment because they have the potential for negative side effects. One of the real nice opportunities with early intervention for psychosis is that psychosocial treatments like family and individual therapy, school support can make a difference and might prevent the need for using medications for treating the symptoms. And when we're thinking about outcomes, a lot of the studies are really looking at the idea of, can you prevent what's called conversion to psychosis, the development of a psychotic disorder? Can you prevent that from happening? I think it's kind of funny because it sounds like, people are considering choosing psychosis as their religion. But there are other really important outcomes we're really thinking about in our center. Can we help people improve their social and role functioning, maintain their cognition, help them continue to function in school? This is a complicated slide talking about that same thing. Whereas the earlier that you identify symptoms and provide treatment, the more likely it is that you might be able to use a non-medication treatment in order to help to benefit the person that's experiencing signs of risk for psychosis. So you can talk with kids about psychosis and help by recognizing early signs. So here's a list of some very common early signs, symptoms that are often seen in young people who develop psychotic symptoms. In looking at this list, you'll probably notice there are many on this list that are present in every single kid you see in your practice. That does not mean, of course, that they are all developing psychosis. It just turns out when a young person is developing psychosis, they often have some of these showing up as well: trouble concentrating, decline in self-care, social withdrawal. And then some of these experiences are more, sound more psychotic-like, like suspiciousness, feeling like your mind is playing tricks on you. Here are some example questions that can be useful for screening for psychosis, for starting to ask. I'm curious, just a quick maybe show of hands or thumbs up in the chat or something along those lines. How many people routinely screen for psychosis in their practice currently? Hard for me to see exactly how many thumbs up. I think there are some, I see some thumbs down. I think it's very often the case that figuring out exactly how to ask about psychosis or regularly asking about psychosis is not something that's regularly done. I'd say, I think it was the majority if I sort of read my Zoom screen correctly. And I think that's very common. I think a lot of times folks aren't given good tools to screen for psychosis. A lot of time folks don't really know if a kid endorsed some of these items, what exactly they would do about that and what that would mean for the kid. Some people have been trained on a couple of questions about psychosis. There's a very popular research-based instrument called the SCID, the Structured Clinical Interview for the DSM. And when you ask about psychosis on that interview, you're supposed to introduce the psychosis section by saying, now I'm going to ask you about some unusual experiences that people sometimes have. And I don't like that question. Can anyone guess why I don't like that question or use it?
It implies judgment or like a negative connotation, like that it's odd, you know, whatever. It has some judgment to it.
Thank you. Yes, big time. And especially for teenagers. Oh my goodness. You don't want to tell them something's unusual and then not start asking them about it. Then it's like you're already saying, well, if you say yes to this, there's something weird about you. Like you have to preface it. So I don't recommend doing that. But these are some questions my colleague Barbara Walsh at Yale has shared. And I really like to pass these along that are very open-ended. Some kids will say yes to these things and not have psychosis, but if they do, they might be likely to tell you with some of these questions. Do you ever feel like your mind is playing tricks on you? Are you ever confused about whether something you've experienced is real or imaginary? A lot of these questions are just, they open a door for talking with a kid about unusual, or I'm using the word unusual, just confusing experiences that may be coming up for them. And if somebody says, yes, I'm experiencing this, here's are some examples of some follow-up questions that you can consider. So here I've got a very deliberately vague, not necessarily psychotic experience. Young person might say, I think my house is inhabited by spirits. So some questions, follow-up questions that can be helpful. These are the kinds of things that we will ask when folks come to see us or they call us. Tell me a little bit more about that. What do you make of it? How often are you having that thought? Do you do anything differently? I think this is a really important thing. Oops, sorry. Do other people in your family or culture believe this too? This is super important because again, when it comes to some of these kinds of experiences, you do not want to be labeling somebody's culturally normative or subculturally normative belief as being pathological, psychotic. We really want to understand the context that the belief is coming from. At our center, we have to do a lot of research on conspiracy theories and TikTok campaigns and things like that, because there's a lot of stuff that comes up that might sound like psychosis. And then it turns out that, that most kids that are on TikTok are seeing something that's very relevant for this. And that belief makes a lot of sense within the context of that. So really getting a sense of, does your friend group believe this too? Does your family believe this too is an important thing that we think about. This is a questionnaire. If folks are interested in a self-report questionnaire, this is, we can share a link to this in the chat. It's a 16-item questionnaire that asks about a variety of experiences. It's a useful way of starting a conversation with a student that you might be wondering about. If they answer yes to 6 or more, they're a little bit more likely to also meet criteria on the SIPS assessment that we do in our center. However, it's not a hard and fast rule. It's just a good conversation starter with folks as well. And some of our colleagues have done research on a 2-item screen. So if you're interested in just adding 2 items in your school, these were the 2 questions that were found to be the most useful as a 2-item screener. Again, you're going to have some false positives, false negatives, but the 2 questions they found that were most useful in this research study were, do you ever hear the voice of someone talking that other people cannot hear? And have you ever felt someone was playing with your mind? So I'm going to say a few words when folks come, when they call us about a young person that's disclosing some experiences that might be related to psychosis. We're often asking some questions, or when folks come in to do an assessment at our center, we're asking some questions to differentiate from some of these other kinds of experiences. Now, many of these experiences can co-occur with psychosis risk, but some can overlap and be confused with. So we see some kids that have overlapping OCD and signs of clinical high risk. An example of that might be a young person who's having intrusive images that are bothering them, and they're also very concerned that their neighbors know what they're thinking and can tell, and might be standing outside their house watching and waiting for them to have those thoughts, versus someone who's just having images that are very embarrassing and upsetting to them. Late onset ADHD is not a real thing, that doesn't exist, but a lot of kids who are in the process of developing psychosis may first notice some changes in their attention and their concentration, leading them to wonder if they have ADHD. And when somebody presents for the first time with concerns about attention and concentration, and they're a teenager and it's never shown up before, it is worthwhile just to inquire about a family history of psychosis, about other kinds of experiences like this, because the medications that are used to treat ADHD could make psychosis symptoms worse if someone's in the process of developing them. I want to make sure we have enough time for some other things. I don't think I'm going to go into great detail about overlap with trauma, autism, social anxiety, but I will say we do a lot in our center in terms of trying to get a sense of whether the symptoms, experiences the young person is having may be better accounted for by these other diagnoses or other challenges, or whether they might be co-occurring. Now I'm going to turn things back over to Colette to talk about how to respond when you see signs of risks.
Okay, it sounds like a lot of you have so much experience, so I'm sure you're responding this way anyway, but this is just really helpful to the student, to the participant, to the family if you respond with hope. Because there's a way to intervene, there's a way to treat it. A lot of people don't know that. And the way you respond, if you are the first person you were there when they first disclosed this, the way you react has a huge impact on whether or not they go on for treatment and how they understand that treatment moving forward. Thank you for trusting me with this. All the things we said about stigma, how hard we make it culturally, we make it so hard for kids to disclose this. So when they do, I'm sure you don't take that lightly. So just thank you for trusting me with this. There is help for this. That will probably surprise people, but it's good that they know that right off the bat. And this is more common than you think. A lot of our experience with kids, and I'm sure yours too, kids think they're the only ones who are experiencing this, except for TikTok. Everyone is experiencing it on TikTok. But just normalizing this, like this is more common than you think, but people are, and I ask kids sometimes, like, why do you think, kids think it's only them, and they will answer that question, which is, it's hard to share this. Nobody wants to share this. So just letting them know that you can even share percentages with them, and you don't have to be a mathematician to realize, like, in their high school community, they are not the only ones. And early intervention makes a difference, and we want them to know that, like, the quicker you move, the better you'll feel. So we're moving on into resources. We've got a lot here. I'm going to share with you some of the studies that we have at Response to Risk that offer free treatment. Everyone loves free stuff, and it's really good. One of the things that we offer is a family therapy study. It's called Uplift. And what we're doing is we're investigating 2 types of treatment in treating clinical high risk. I'm the clinician. I forgot to mention that at the beginning. I'm a family therapist. I am actually the clinician on this study, so I am the one treating families. With this, before you get into the study, we want to determine eligibility. So kids get a pretty comprehensive battery of assessments. They get the SIPs that Michelle was talking about, but they also get really good diagnostic information that is incredibly useful and difficult to get as quickly as you can get it through research. So families are finding this incredibly valuable while they sit on waiting lists at other places. Christine asked, these are all on Zoom, so you can do anyone in the state. And it's 6 months of family treatment. It's no cost, no insurance. I will tell, it's for families that are pretty high functioning and they can complete quite a bit of study paperwork. We will be asking them for all kinds of stuff, but 100% worth it for most families, because the treatment is incredibly valuable. Another wonderful thing is that the participant, the student, or the adolescent will get follow-up treatment. So they'll not follow-up treatment, follow-up evaluations 6 months in, 12 months in, and 18 months in. And this is also another valuable thing for families who really want to know that people are paying attention to these symptoms and whether they're getting worse or they're getting better. And this comes with feedback, clinical feedback, recommendations. It really is quite wonderful. Can't say enough good stuff about Uplift. But I'm going to say good stuff about the school coaching study that we have too, which is also free. And not even just free, because it's research, students will be compensated. So for sitting for the evaluations for that portion, kids will get compensated. So this is for youth ages 12 to 18 who are at clinical high risk. So we're having some of the symptoms, the threshold that Michelle shared. This also comes with a free clinical interview. We do the SIPs, we assess for risk. There's a little neuropsych testing, and then 4 months of free coaching. And so this would be done, this is also done on telehealth. And so this would address things like task initiation, procrastination, setting goals, kind of the executive functioning, how to stay organized, how do you attack your homework, how do you do projects, how do you plan for the future, things like that. And that one's also, it's really great. Some of our coaches are in the audience today, and they're just wonderful, like really great role models that you would want for some of the kiddos in your school. If you have questions about any of this stuff, you can call me. My number is all over the place. I think my number is listed everywhere. The email will go right to me. Yeah, I love talking to people, especially people who attended our presentations. And I'd be happy to talk further about any of this with you. This one is not open yet, opens on Friday, but this is another one that comes with a whole host of assessments and clinical assessments and diagnostic clarity that people are really, really looking for. Like Michelle said, like by the time they get to us, there's a lot of confusion about like, what diagnosis is this? Is it depression? Is it anxiety? Is it social anxiety? Is it OCD? Is it AFD? So we really try to tease that out just so that, we're studying the right group of people, but also it's super valuable because it doesn't cost anything, and it's we just don't have the waiting list that clinics and other agencies have. So this is a more expansive group. This is the whole age group that we're studying, which is 12 to 30. But like Michelle said, before 12, we're not looking at risk for psychosis yet. And after 30, we're also not looking for a risk. We're thinking more there was a first episode if there was anything. This is a little bit longer. Over a 2-year study, includes brain scans. Anyone who's ever done research studies knows that anything with the brain scan, the compensation is not bad. It's $30 an hour. And it's kind of maybe more time intensive for the first couple of months. So if someone was looking for like a part-time job for a couple of months, maybe when summer starts, this would be a really great fit for kids in your school for sure.
A couple of things I jumped in.
Yeah.
I've been answering the chat. So all of these can be done with anyone in Massachusetts. Unfortunately, we can't. If somebody traveled from outside of Massachusetts to Massachusetts, we could do it, but we can't meet with someone outside of Massachusetts. We do have capacity for most of the studies to be able to do a consent in another language with parents that may be speaking another language, but the kid has to speak English, unfortunately, at this point right now. And the other thing I noted is this ProNet one. I think we will also be enrolling so-called healthy controls. So folks who don't have clinical high risk. So this could be of interest if you just, like for kiddos who might be just interested in research and getting pictures of their brains and stuff like that, we can send information about that too, because we will be also enrolling comparison folks, because this study is really interested in trying to understand changes in the brain and trying to set up a system for being able to develop new treatments that might, and they're kind of using a model similar to what they've done in like AIDS or in Alzheimer's, where they're trying to kind of develop new medications and treatments and have like a very standardized battery that would help to identify something that would prevent the progression of illness. So they're looking at kids with CHR and also other kids.
So a lot of takeaways from this, but this is really great. This is brand new. This is just out for a couple of weeks. I got some questions asking about the SIPs and should adjustment counselors be administering the SIPs. It takes a long time to be certified on the SIPs. It's a very long clinical interview. We wouldn't expect that you would have that training, but we do, and we are offering, this is a study. This is called a data repository study. But what it is it's essentially a free and fast SIPs. So we're at the ages 12 to 25. We're looking for kids in this age range or young adults who seem like they could be at clinical high risk. That we would do a phone screening. There's a link to like a quick the PQ16 that Michelle shared. Students get $30 for sitting for the interview, and what kids get is the 2-hour clinical interview with a trained clinician, self-report questionnaires, and then clinical feedback from the clinician, which is really great. Like, this is what we found, this is your level of risk, in addition to like a written clinical summary that they could then take to their PCP, their therapist, their prescriber, and $30. So we have no waiting list for this. You can, I don't know if Finn is here. Can you put a link to this study in our in the chat? Yeah, that's it. I don't know. It's just great. I don't know what else to say about this. This is great. It's fast. I do want to address, like, we get this a lot where parents are like, I don't really believe my child. And there's just some, just a lot of doubt. And who knows if that's coming from a place of fear or a place of just, kind of annoyance. But this is a really great way to say, like, you know what, we should just double check, because if it were real, it would start right now. And so we just want to take it seriously, and we can have the experts be the ones to let us know, is this real or is this not? And this is very, very quick. We're scheduling people even for I just scheduled one today for Thursday, and they'll get clinical feedback within the week. So it's amazing. And then Michelle, I think I'm gonna have to hand it to you. I could talk about these studies all day, so please call me. And also we offer free clinical consultation. So like Michelle said, if you're worried about a student, call this number, email, it's me. I talk to people all the time. In fact, I recognize some people on this call because you have already called me and we've talked through some things. And sometimes it's like, the person does not seem like they're at risk for psychosis, and we just chat through it and then we get off the phone. Other times it ends up as a referral, and they come through and they get evaluated. But just if I could support you in your work, I'd be happy to do it.
Yes, if we didn't get a chance to answer your question yet, feel free to send the question to this email address and we will be happy to answer it as well. Just a few extra words on resources I wanted to share that are non-research. So there are 3 specialty clinics for clinical high risk for psychosis in Massachusetts. There's Cedar Clinic, Reset Program, and Star Clinic. And Massachusetts recently got a grant from SAMHSA to develop a program that's allowing all of these clinics to start to work together to coordinate, to be able to expand the availability of treatment-based resources for kids at clinical high risk for psychosis. Another thing, I don't know if you guys are aware of this. This is something that launched on January 3rd of this year. It's called the Massachusetts Behavioral Health Helpline. This is a 7-day per week hotline available for all Massachusetts residents. More information can be found at that link. You can call or text that number and get connected to a person that will help you think through, you or a young person or a family member, first assess for risk and emergency, but also their mission is to provide a warm handoff to clinical care. So this is an amazing resource. It's brand new. We're still finding out how it's going to work and whether it's going to work and what the experiences are, but I wanted to share this with you because this is an amazing resource as well. And coming soon is a new program called the Massachusetts Psychosis Access and Triage Hub, or MPATH. And this is going to be a program that works with the behavioral health line that would be a single number. If you are, like right now, if you have a question about psychosis, email us at response to risk. But once this is up and running, you also have this as an option to ask about trying to find treatment assessment for someone who might be at clinical high risk for psychosis or who might have full psychosis. And they will be working on knowing which programs have availability, helping people match people so they don't have to call, 5 different programs. The hope is eventually there'll be one program that can be called. So a few words. I realize we're right at 4:30. Just want you to leave this knowing that psychosis is treatable, especially when symptoms are recognized early. Psychosis is more common than you might think. We really think about it on a continuum. You might be the first to recognize signs of risk. And we will stay on for a few extra minutes if folks have questions, but Finn is going to put in the chat the link to the post-event survey. Please fill this out. Whether or not you're getting CE credits, we really appreciate your feedback, your questions, your attention. I really appreciate all of your just really thoughtful participation today.